Thank you very much, and I'll try to finish in 3 minutes. Otherwise, you can cut me short, whatever, because 5 tips in 3 minutes is slightly different. Thank you very much, anyway, KSOS, for having invited me here. And the first tip that I am talking about is saving time for high volume surgeon, and that's a simultaneous incision, so you don't have to hold it separately. So what we do is that we hold the side port. That becomes the stabilizing hand, and then you use the main port, go in while the left hand is now stabilizing. So that's exactly, and once you have gone in, not fully, you pierce with the side port and then go in. So this is the first tip. Single throw 4-pass pupilloplasty in phakic eyes. Amar described it in a phakic eyes or pseudophakic eyes. But this is in case of a blunt trauma, the patient had traumatic mydriasis. So what we do simply in this particular tip is that we put in a lens, a plate haptic lens, and then go ahead, because you need a support. Otherwise, with this long needle, you can go and puncture the anterior capsule of the lens. So you go ahead in this particular case, and you will complete the SFT. In this case, as you can see, we are able to do this pretty well. And once before tying the suture, but we have already got the sutures entangled, we remove the lens and then go ahead and do the pupilloplasty, the completion of the pupilloplasty. So this is my second tip for you. And then if there is a small pupil for people who do a femto, this is our own BX ring. So you can use a BX ring, as you can see in this particular case. So this is again a tip that a femto is not contraindicated absolutely in case of small people. So you can see here, this is the BX ring in position. You have done a capsulotomy and you have done a nucleotomy, and then you have removed the BX ring. This is a technique of patients who have an iris prolapse in, subluxation of the lens, and you see a vitreous here. In this particular case, we have described limited pars plana vitrectomy. Thanks, I have 1 minute more, yeah. So you can see in this particular case, what we do is that we can have the pupil centered. In this case, what I'm showing here is that we have gone in from the pars plana, and we have done a femto before that. What is important here is that you are decompressing the vitreous. That is something important, that you use the third hand, as I call it. And once you are using that, you are able to and put a CTR in this particular case, and really remove the nucleus and the cortex, etc. But this is always there, the third hand to any, so you are not over hydrating or over filtering, over infusing the vitreous and causing more and excessive vitreous loss. So this is again the last one, that when you are using having a posterior polar cataract, the imaging helps you see in a femto laser. So you can see this is a pre-existing defect which is very clear. This is a polar cataract. So what we will do in this particular case is to do a femto. You can see here, this is a big defect which is there. So the OCT is the guide for you in the, so this is a pearl that I would wish to say, that in any posterior polar cataract, you can see this is an intra-op OCT. We have done a good capsulotomy, we have done a nucleotomy, so we can remove it. So there is no loss of vitreous. You can still see that in the intra-op OCT that there is a dehiscence which is there, and it is only at the extreme end because you have raised the default, and it is here also that the vitreous is herniating. So the key here was that when you have the OCT image which is available to you, you just raise the OCT image so that the default which you have is not the nucleotomy, is of giving you a great epinuclear cushion. So this is the key, that you are raising it, and this is the tip so that you can get a good nucleotomy which is there. So these are my 5 tips for various things that we have in the femto and the phaco to make things easier for you. Thank you very much for your kind attention. Thank you.
Thank you so much, sir. I request Dr. T.P. Lahane to come forward. Sir, one question to you.
Yeah.
Where the case where you put B-hex and then took the patient for femto,
Yeah.
the AC is formed with?
So if you can leave the viscoelastic, you just increase the energy settings. If you want to aspirate it, then put a suture.
Okay.
If the viscoelastic is removed, you fill it with the BSS or whatever.
And put a suture and send for femto.
Then, yeah, under aseptic conditions. Okay. If you leave the viscoelastic, there is no need for that, but that again has to be under aseptic conditions.
And we are using the Zemer now. So that is used in the same room, and so we are not shifting. So we can use it in the same room with a sterile head and everything sterile also.
You are absolutely right. So it depends on, there are a lot of people who have the femto and the phaco in the same room, so that can be done. But all that I'm trying to say is that a small pupil can be
Not a
managed with a femto.
contraindication for. Thank you.